loading this to a NACE website for those that cannot stay on for the full 2 hours and would like to come back to it at a later time. I want to go ahead and introduce first Dr. Pamela Jumper-Thurman, who was one of the initial developers, along with Dr. Barb Plested, on this particular model 17 years ago. And I will let Pamela introduce Barb, but again, I want to thank both Pamela and Barbara for their participation.
Thank you, AJ. We are very pleased to be able to have this opportunity to present community readiness, and we wanted to mention that we represent CASE, the Commitment to Action for Seventh Generation Awareness and Education, and we are funded by the Centers for Disease Control and Prevention to provide capacity building assistance for HIV and AIDS prevention and testing. Our HIV focus will be pretty prominent throughout the presentation, but I do want to point out that this model can be used for any topic or any issue, and it's very likely that if you're working with substance abuse or violence or child abuse prevention, we already have a set of questions that have been developed that you could always contact us, and we'd be happy to share those with you. I am Pamela Jumper-Thurman. I'm Western Cherokee from Tahlequah, Oklahoma. My PhD is in clinical psychology, and I've been working here as a senior research scientist at Colorado State University for about 20 years. And my co-presenter is Barbara Plested. She is from Detroit, Michigan, has an extensive history in directing and administration of various service facilities. She's done jail-based work. She's done, not as a prisoner, but as an administrator. And she's also worked here at Colorado State University as a research scientist for 20 years. We wanted to mention, because it's very important to bring this to big focus, the National HIV/AIDS Strategy is one of the most prominent policy priorities right now. And basically it includes 3 goals. One is to reduce the incidence of HIV. One is to increase access to care and really optimize the health outcomes. And the third one is to reduce HIV-related health disparities. The President's National Strategy was released in June of 2010, and it really does call for unprecedented levels of coordination among the federal agencies, the state agencies, the tribal groups. We really have to work to achieve these goals so that we can better coordinate our efforts. The Native focus part of the plan is much smaller. However, it does use a variety of approaches, with community readiness being one that really stands out as a culturally focused and cost-effective method. We are helping communities to spread the messages of really to know your status, to make testing routine and improve access for your communities to care as well as to treatment outcomes, to reduce transmission and new incidents of HIV, and to ensure quality HIV services and increase the survivability of the disease among American Indians and Alaska Natives. We tend to die sooner after we are diagnosed, and it's important that we follow these national AIDS strategies. Our partners in our endeavors are the Center for Disease Control and Prevention, the Indian Health Service, Office of Minority Health and Research, Substance Abuse and Mental Health Services Administration, the National Native Network that works with HIV, and the National Native HIV/AIDS Awareness Day Committee. What we offer on this project is to increase the capacity of a community or an organization or a social network within a community to implement HIV/AIDS prevention and testing by offering the Community Readiness Assessment, the provision of a Community Readiness Diagnostic, a Readiness Workshop, a Community Readiness Action Plan, social marketing strategies that are built into that action plan, and then we follow up with technical assistance as needed.
AJ, just a second. We're having trying to move the screen.
I'll go ahead and keep talking even though the slide isn't up yet. Basically, what we want to do is teach people how to mobilize their community with this particular tool. And one of the new buzzwords that seem to be making the rounds throughout CDC and SAMHSA right now is to build the capacity of a social network, or particularly high-risk groups within a community or an organization. And community readiness does that very well. I always like to start out a discussion about community readiness with a native story. This particular story is about Turtle and Lightning. One day, Turtle and Lightning were sitting on the riverbank and they were visiting. They hadn't seen each other in a long, long time. And they wanted to share information about themselves and their families. And they talked, and they talked. Darkness came on, and they wanted to continue talking because they really weren't quite through and wanted to visit with each other a little bit more. But it was chilly, and they needed to build a fire. Turtle said, "I'll build a fire. Let me do it." Now, Lightning knew that he was really good at fire. However, he thought that he should let his brother Turtle build a fire. So Turtle has little bitty legs, and he went over and he got a twig and he brought it back. He got another twig and he brought that back. After he'd done this several times, Lightning was getting really impatient because you know that's how Lightning is. So finally, Lightning couldn't stand it anymore, and he threw a bolt and he started the fire. But he scared Turtle so badly that Turtle grabbed his shell and dove down to the bottom of the river, and that's where he lives to this very day. Now, the reason we like to tell this story to prepare the foundation for community readiness is that many of our communities are like Turtle. They have to do things in their own time, with their own resources, and when they're ready to do them. As providers, sometimes we can come in like lightning, and we know that this is our field. We know that this is good, and our readiness level is probably much higher than the community. So we have to be cautious not to come on like lightning and scare the community so that they go away from us. We want to engage them and bring them on board. The purpose of the community readiness model is to provide communities, organizations, and social networks with the stages of readiness for the development of appropriate strategies that are more successful and cost-effective. And when we say appropriate, we mean strategies that are appropriate for the community and the culture. We know that communities are always ready for something. It's not an issue really of whether or not they're ready, which is sometimes a misinterpretation, but more an issue of what are they ready for. Community readiness came about with a great sense of synchronicity because at one point Barb and I were in Canada and we were working with Native groups, and we were new to the center at that time. Both of us had come from working in direct treatment. And we were with Native groups that represented 5 reserves. They all came from different areas of Canada. Since our treatment background was really prevalent at that time, and we had both used Prochaska's model of treatment readiness, when we divided people up into groups to decide what they would do related to preventing inhalant abuse in their communities, we realized that they were really like individuals who were coming into treatment. They all had different resources, they all had different social structures, and they all had different kinds of political systems that they had to engage in order to implement any kind of prevention. And so we talked about that later, that it really did fit Prochaska's model of treatment readiness as well. At the same time, 2 other colleagues were working on a media campaign that was national in focus and looked at the development and testing of media programs that were aimed at preventing alcohol and other drug use in rural communities. They brought youth in from all over the United States, and those youth groups formed teams. When they did the follow-up, they found that after communities returned home, after intensive training with media, video equipment, everything, some had done amazing things in the communities. Others had done nothing. So when they did the follow-up, they found out that most of the communities said, well, our community wasn't really ready for media yet, or our community was ready for one part of media but not another. So it was a readiness issue, and they brought that to the table. Our center's scientific director, Gene Edding, had attended a conference in Kentucky the week before, and he had heard the term community readiness used by Mary Ann Pence, not with a model to back it up, but just a term about general readiness. When we all came back and shared our experiences, community readiness was born out of that particular discussion. There are theoretical foundations for community readiness that we utilize to build the model. The first, of course, was treatment readiness, based on mine and Barb's experience by Prochaska, DiClemente, and Norcross. The second theoretical foundation was the decision-making process used by Rogers and social action used by Warren.
All right, and this is Barbara, so we're going to change presenters now. To go over what exactly the model is, just kind of in a real quick slide, it's a model that really mobilizes a community, organization, or tribe looking at healthy changes within that community. We have 9 stages of readiness, and within the model there are 6 dimensions or aspects that we look at within that community or tribe. And at the end of the assessment phase, each of those 6 dimensions gets a score or readiness score associated with it. And each readiness stage has specific interventions that are in our manual and that we'll present today that work when a community or tribe is at that level of readiness. So if we're at a denial level, what should we do? We have some things that other communities have done that can be obviously modified, and we want communities to do that, but just kind of the essence of these are the types of interventions that work at this stage of denial for this dimension. And of course for us, and I know for everyone on the line, it integrates the culture of whatever the culture is of your community. And this has been used for Native communities, Alaska Native, African American, Hispanic, Latino, the Hmong community, and it's been used in over 30 that we know of foreign countries. So whatever the culture is of that community, to integrate that into the process. Because we know, and I think probably everyone that's on this line understands this, is that trying to implement something when your community isn't ready to do it is really costly, not only financially but also in terms of human resources and time. This has just kind of been our motto, really our mantra since the beginning, because we have seen this through the 3,000 communities that we've worked with, is that never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has, attributed to Margaret Mead. And so the model itself has 2 separate phases, the assessment phase and the application. And to begin with, we're going to start with what that assessment phase looks like. So for many of us, and we've all done assessments within our organization or assessments within our community about a variety of issues, substance abuse, mental health, suicide, you know, the list is endless that we've done. And normally what those assessments do is get at the truth. And sometimes, and what this model does differently is it may not get at the truth, but it gets at the community's truth, which is really the community's perception and their reality. And sometimes they're not aligned. The real truth and the community's perception may not be the same. So for instance, when we go into community, I'll give an example with community efforts. When we ask questions in community readiness about what's available in your community related to efforts related to HIV prevention or treatment or testing, and we hear from the 6 people that we interview or the 20 people that we interview, and this happens often. Either there's nothing available within our tribe or our community, or we hear of maybe one project. So we go to the community and say, well, for efforts you score at denial because there aren't any, and we have sitting at the table service providers from 10 different organizations that provide services within that realm of HIV. It's a great way to say to them that maybe one of the strategies is we need to do better marketing and educating our community of what's really available within our community. So it's the community's perception. If that is how they think it is, that there's nothing here, or that maybe our leaders aren't really involved, or that we don't have this problem in our community, that's what people need to know who are running these programs, to say what kind of strategies do we need to implement within our community so that we can change the perception and the reality of our community to be more of the truth that's happening. This is the process that we go through, and you know, as Pam had said, we are funded by CDC, and so our manual and all our resources are free to anybody that's on this call or to anybody anywhere. And we have a manual that talks about this whole process, that you can do it on your own or we can help you with it. But it's the first initial thing is to really identify the issue that you want to look at within your community. Then defining that community, conducting those interviews, scoring them, then conducting a workshop on the scores to develop an action plan, and then implementing that action plan. So identifying the issue. What we have found is that in communities that we've worked with is to be very specific. What is the issue? So for HIV, is it really HIV testing that we want to know within this community? Is it prevention, or is it treatment? And all of our communities are a little bit different. They may want to know about one, and if they want to know about all three, we'll do 3 separate types of interviews because the answers will be different for each one. A really good example would be substance abuse. We get a lot of communities that say we want to use it for substance abuse, and the problem is when it's not specific, are you talking about alcohol or methamphetamine or heroin or cocaine or whatever that drug is. When you do the generic substance abuse, your questions or your responses really don't target the issue that you're getting at, because communities' readiness to deal with alcohol, in our experience, is much higher than a community's readiness to deal with methamphetamine. So to be very specific about that issue. And then consider related, or we have it in quotes, you know, safer issues. For us with HIV and AIDS, and it's getting, communities are getting more ready to deal with that issue. But safer issues 10 years ago for us when we started this project were things like health issues in general, of cardiovascular. Can we get into communities that way? Can we get in on methamphetamine? We have communities that are very interested in talking about methamphetamine but didn't want to talk about HIV and AIDS. So meth was a great inroads for us to talk about HIV or meth up front, but then to talk about how meth then puts people at risk for HIV and AIDS. So to really spend some time about thinking about what is the issue that we want to address, and then defining your community. And so for us, when people call us to do the work in their community or tribe, we work with them on defining what community they want us to look at. Is it a geographic region? Is it a subgroup such as like age, or do you want to break things down by ethnicity? Is it a social network that you're looking at? Occupational groups? For HIV and AIDS, you know, it could be medical, it could be law enforcement's concerns about arrests and keeping people with HIV and AIDS in their facilities, which has come up across the country, mental health systems, organizations, and the list goes on and on about how do you define the community, and we will work with any group to define that and what fits best with them. And then we conduct the key respondent interviews, and again, you all can conduct those key respondent interviews in your community. But who we interview, really, it kind of depends on the issue, but this is just kind of an overall view of who we would interview for HIV and AIDS. Would be someone working in prevention or treatment of HIV and AIDS, someone in city, county, state government, or tribal government, health or medical professionals. We always interview a community member at large in any of our projects, and that's someone who is not being paid to provide services within the domain that you are asking questions about: social services, elders, spiritual or religious community, school or mental health or treatment providers. Again, this list, obviously the list can go on and on, but these are the types of people. We like to get a cross-section of the community when we do the interviews. And then when we conduct the interviews, we have 20 to 35 questions, and the 20-question form is really a short form with the key questions that we need to actually score an interview. But what we have found in communities, especially with suicide, those interviews need to be done quickly because they want to actually get an action plan done. So the more critical the issue is, we can use a short form. The 35 questions gives us just a much richer interview and more information that we can take back to the community. They usually last 30 minutes to 60 minutes. Some people, when you do an interview, may say, I don't know to all the questions, and so it's a very short interview, but that is just as good and just as valuable as the interview that may last an hour. When you're conducting those, is to really make sure the interviewers that are doing the interviews really understand the purpose, the issue, and how these results are going to be used, because that's pretty much people's questions on the phone after the intro is, what are you going to do with the results? So to really educate the people that are interviewing on the phone or in person what the purpose is of it. We do telephone interviews here. Once in a while we'll do face-to-face, but we do telephone obviously because of traveling to communities to do interviews is pretty costly. So we do them by phone, and if we have to, we'll do face-to-face. We do not, and we highly recommend that people never send the questions to the people that they want to answer them. And the reason is because people go and find the truth. They go and find the right answer. So you don't get perceptions, you get so everybody scores very high. They have a high level of readiness because everybody went to their directory to look what they had, and they talked to everybody about what they offer. So we avoid the written format. And then to ask the questions just as they're written and avoid interjecting any kind of personal bias or opinions. And I know you all know that, but sometimes it's really difficult with the issues that we and you are dealing with HIV and AIDS and domestic violence, and sometimes, alcohol use. We hear things on the phone from people that may go against our grain or go against our values about the issue. And so to let them talk, and our motto here is, if you're going to ask the question, you have to be ready for the answer, and to just let them say it, because we really do want to know what people's opinions and perceptions are within the community. And then we record the responses as accurately as possible. We type as we go, and we've done this for a long time, but you can write the responses, and when people talk quickly, we let them know, I'm writing right now, and we restate the comment that they just made to make sure we have it right. And again, there is no right or wrong answers in our model. There's no good or bad interviews. They all provide essential information. Sorry. Okay, and then the dimensions that we have within the model, and each of these dimensions have questions under these dimensions. But what we look at is community efforts. So what's currently available within your community or tribe, programs, activities, and policies? What's the strengths of those efforts? What's the weaknesses? How long have they been in existence? And who do they serve within your community? And then knowledge of those efforts. So what does the community know about them? Do they know how to access? Do they know who they serve? Do they know the criteria? Information about knowledge of those efforts. And questions about leadership, and not only appointed leaders or elected officials, but also influential people within the community or tribe. A really critical dimension, really for all communities, but especially for tribes and smaller rural communities, because leaderships in those communities really can hold the purse strings and the support and motivation for other people in the community to be involved in your issue. So for example, if leadership is active and supportive, you probably will have more people at the table when there's approval for that issue. However, if people are possibly even involved in the activity that you're trying to prevent, such as maybe a heavy drinker and you're trying to do alcohol abuse prevention, or a domestic violence perpetrator and you're working in domestic violence, it's hard sometimes to get those people on board, and then when you do, the community sees them as, why are they at the table? So questions related to leadership are really important to bring back to the community to say, this is where the community thinks leadership is, and it's not in a judgmental way, it's just in community's perception of the leadership. And then community climate is really, what kind of community or tribe do I live in? Proactive, very positive, or is it a community or tribe that possibly is sad and depressed and only reacts to situations? And then community's knowledge about the issues, so about HIV or AIDS, or if it's alcohol or domestic violence, but do people know the signs and symptoms? Do they know the local stats within your community or tribe related to that issue? And then resources that you have within the community. Different than efforts. Resources are more people like volunteering their time. Do you have space available to have events at? The land, your rivers, all of those kinds of resources that when we come to a community that we can talk about and say, so how can we implement and put these resources into an action plan because they're already here and we don't have to look for funding to implement. And then these are the stages of our model. And for all of you that know about stages of change, either Prochaska or stages of change by Elizabeth Kubler-Ross, Death and Dying, all stages of change start with denial, and ours doesn't. Ours starts with no awareness. And really this was actually put into the model about 2 years after the first publication because of feedback from a tribe that we were working with that said, you know, we are not at denial. We are a little bit below denial because it has just become a way of life and the norm. We're not denying that it's here. We're just saying that there's nothing we can do about it anymore, and it's kind of who we are. So ours starts at 1 and then goes through high level of community ownership. So with no awareness, when we do the interviews and score the interviews, these are the types of comments, and you probably can, you know, think of the issue that you want to use the model for, whether it's HIV or another issue, and really kind of hear these things maybe in your community. We hear that it's not even recognized as a concern in our community, or it's just the way things are, or the issue really doesn't exist in this community. And for some issues, not recently, but when meth first hit everybody's radar, let's say 8 to 10 years ago, there were some communities that legitimately did not have meth in their community. Now, we don't think that that's true anymore, but you know, we're on a webinar today, July 12th, 2011, and there's an issue or a drug or a concern that is happening somewhere in the world that we are not aware of, that will hit our country or hit our community maybe in the next 5 years that we are not aware of. So it really has kind of two definitions. It's just the way things are, or you know what, it truly does not exist in our community. And then for denial and resistance, these are the types, and I'm not going to read them all, but you know, it's just not our concern. We can't do anything about it. The issues overlooked or ignored by the community. Vague awareness, you know, it's really kind of stereotyped. It's kind of those people do it, but there's some people in the community that say this may be a concern. And this usually happens, for many of you, I know you attend meetings on other health issues with whether it's tribal leadership or community organizations, that people are sitting around a table about diabetes and the issue of another topic comes up of, you know, yeah, we're seeing diabetics, but you know, we're also seeing now, we're getting more people coming in HIV positive, or we're having more people come in reporting alcohol addiction or whatever the issue. So it's that kind of that seed is planted that, you know, maybe it is a local concern, but the community at large really doesn't support any action because their awareness isn't there that it's in our community. And there's no identifiable leadership for the issue at this point. And then pre-planning, this is when, this is really kind of the fun time, the next couple stages. You know, it's that fun, active time on committees and in communities where, you know, there's discussion that something should be done about the issue, but there's no focused planning, but things are starting to kind of move a little bit. People are talking about it. There's a clear recognition that, you know what, we do have this issue in our community or within our tribe, and we need to be concerned about it. And then when a community is at preparation, these are the types of things we hear during our interviews. We have resources are being actively sought. We have a lot of information is being collected on the issue because we know it's happening locally. There's planning going on, and people are actually meeting as a group or as a committee within our community to do something about this issue. And then at initiation, and most of us have, for HIV and AIDS, most of us are at this stage of readiness. In most of our communities, probably 95% of our communities, have some form of HIV, whether prevention, testing, or treatment available within their tribe or community. So there's local information and data is being found. Things are underway. You know, you're recruiting staff and you're training people on HIV or substance abuse, and people are really motivated to do things. Programs are in place and things are happening. And then stabilization, which is our 7th stage of readiness. So there's 1 or 2 efforts are stable, and stable for us in our scoring process means 4 years or more things have been in place. And the reason we select 4 is that so many grants, especially over the last 5 years, it used to be 5-year grants from the feds, but most of them now are 3 years. And so we select 4 for stability because grant-funded programs can come and go, but when things are stable, they need to be there for at least 4 years. Programs are viewed as active and established, so things are in place and moving along. Evaluation is happening, and the community actually has increased their awareness of the efforts that are going on within the community. And then for stage 8, which is confirmation expansion. And I'm sure everyone on this line has been involved in this. We start with an HIV program, and we're going to provide services for HIV-positive people or for substance abusers. And we know at that point, once we start seeing clients or seeing participants, that we need to expand our services, because not only do they need education and treatment, but they may need housing. Or they may need health care. So it's really that expansion and confirmation, and these are the types of things that we hear. Our programs are being evaluated, more resources are being sought, leadership is supportive. So for stage 8, those are the kind of definitions. And then our stage 9, high level of community ownership. This is where things are really clicking. Things are, it's kind of a one-stop shop. People have access to care at one central kind of location. Leadership is very involved. Evaluation is being used to not only improve the program, but to also look for continued funding. And there's communities that have gotten to, that are at stage 9 on some dimensions for some issues that we've worked with in the community. It's really when a community or a tribe has said to a program, because of your evaluation data, you no longer have to write grants, which I think for all of us, is kind of the ideal world. And we will incorporate you into our yearly annual budget as a renewable program, because you have proven that you are cost effective for us to have you in our community. So that's high level of community ownership. And then the interviews are scored to provide each of the dimensions with an overall score of community readiness. And the scoring process looks like this. We use 2 scores for greater accuracy, and we do not score interviews that we've conducted the interviews on. Sometimes it's difficult for communities if they use the model themselves, because you don't have access to, you may not have the manpower to do that. But really 2 scorers need to take part in the scoring process. Ideally, it's also helpful if there's no friends or family in the community. If there are, there's just some guidelines to kind of follow. If you're from that community, to always remember that what I'm scoring on is what this person said about my community or my tribe, not what I know about this community or tribe. So not to add in, oh, they probably meant this, which some people can do in scoring. And then we have a comment section, which really kind of records any irregularities or impressions. For example, if somebody through the whole interview laughs or says, I don't want you to say this in the interview, or really goes from one extreme to the other, we have no programs, to we have a lot later on in the interview, is to really just in the comment section we kind of write that down. And then we remove all identifiers, and we tell tribes or communities that are using the model to not put anyone's name on the interviews in case those interviews are lost or removed from your location, just to keep people's answers anonymous. And then this next slide is the anchored rating scale that we use to score with. So if Pam and I were the scorers on a set of interviews, we would have 6. And we've done up to 50 interviews in a community, so we may have 50. But if we have 6 interviews, I'm going to go through each interview and read it from start to end. And then I'm going to go back and I'm going to highlight all the answers that really dealt with Dimension A, which is what did this person identify as efforts and the strengths and how long. And primarily it's at the start of the interview, because the questions flow A through F on the interview script. And I highlight those in yellow, and I do that for each dimension. So B's interview answers are going to be in green. Use a different color for each dimension. When I'm done with that, I'm going to go back through, and each of the dimensions has their own anchored rating scale. This is just A's, but B has different statements, and C and so on through F. And again, if you want a copy, you can just go on our website, and we'll give you that at the end to get the whole book, and you can see all the anchored rating scales. But what I would do for the first interview is to go back and look at, okay, so everything I have highlighted for dimension A, did this person say there's no awareness for the need for efforts to address the issue? If they did, the stage is 1, which is no awareness. And I start at 1 and I move to 2 to 3, and if I keep saying no, that's not what they said. 2, no efforts, no, because I know they identified it. What I know from an interview, for example, is they said they had efforts running, and they were running for 5 years, and there wasn't a whole lot of planning going on. So I'm going to move from 1 to 2 to 3 to 4, 5. I'm going to kind of look at 6 and say, you know, I know they've got programs implemented. I could move to 7 and say, okay, they said 5 years, it's at least 3 to 4 years, fully expected to run, no plans. They're at a 7 on this interview. That's the score that interview 1 gets for dimension A is a 7. And we go through that process for A through F, and then Pam and I are going to meet, and we're going to say, so for interview number 1, what did you give dimension A? And our inter-rater reliability, and we'll show a slide later, is about a 0.9 to 0.92, that we are going to be so close within that because it's real clear from the interview what was the stage of readiness for this interview for this dimension. So she would say a 7 and I would say a 7. If there is discrepancy, we have to come up with, maybe I missed something, maybe she missed something, but we have to have an agreed upon score for every interview for every dimension. And this is just kind of an example of our scoring sheet so that you can see the top set of blocks for dimension A through F is what I would fill out for each interview, and then when we would meet, then we would put our combined score or our agreed upon score in this second set of the 4 slots there. And then what we do is just add all of the interviews across for A, all of the scores, and divide by the number of interviews that you conducted, and that's the score that would go at the lower left. On dimension A would be a score of 7.5, and for B, such and such. The one thing that we have learned over the years is that at the end of the interview, we ask people, you know, how long have they lived in the community or how long they've worked in the community. And most of the time, it's quite a long time. They've been there for a while. But if it's less than a year, we will automatically call someone else and do one more interview, because a lot of times those people don't know, and they legitimately don't know. It's not because their perception has been formed. They don't have a perception yet because they haven't been there long enough. So that's our scoring sheet, and that's also in the manual. So when we're totally done with the scoring process, then we would come to your community or to any community and kind of do a brief overview of the model, and then present their community readiness scores. And this is just a random example. So we would go in and be able to say to them, so for efforts on dimension A, you scored a 6 at initiation, and so on. B is a 4, C is a 3, community climate is a 3, knowledge of the issue is at denial, a level 2, and resources is at a 5. And from that diagnostic, then we would develop an action plan with the community, and we would help them identify really no more than 2 dimensions to work on, because then it's not overwhelming. And what we've heard from communities is, you know, this allowed us to kind of break this issue apart. So where do we really need to start? Maybe it's just the knowledge of the issue, and maybe we can work with leadership. We know we've got things in place, but obviously we need to get those 2 things a little bit higher within our community for things to really start happening. And I'm going to turn this over to Pam, who's going to talk about the strategies that have been used in communities across this country for each stage.
As you recall, at the beginning of the presentation, we talked about 2 different phases of community readiness. The first one is the assessment phase. The second is the application phase. Barb has described the assessment phase of community readiness, and a lot of groups choose to only do that, especially if they're applying for state incentive grants. One of the requirements is that you assess your readiness and then base your goals on the readiness scores. And so some people just want to know what the scores are. And then others want to take that the step further and do the application phase, which is what I'm going to tell you about now, and that is initiating the change. Our key take-home message is that we truly believe that all interventions must be appropriate for the community stage of readiness and the culture of the community. In fact, Michael Slater, who was funded by NIDA to look at media messages, used community readiness as one of the variables in his study. He looked at demographics, he looked at different kinds of things, factors that he felt would make a difference in creating change in a community. Community readiness scores were one of those factors, and what he came up with at the end of the study was that the readiness score was the key issue that really made a good determination of how successful his intervention would be. Whenever your community scores at a number 1 or no awareness, the goal here is to really raise awareness that HIV/AIDS does exist in the community. Some of the strategies that communities have used and have told us that work are, 1, remembering that this is a very low stage of readiness to identify the potential supporters. Visit with them one-on-one. That's very important at these lower stages. You present at existing and established small groups. It could be a Kiwanis group, it could be a sewing group, it could be any kind of small group that meets on a daily basis or a monthly basis. You look for online resources that you can use later on. That might be posters, it could be educational information, anything that's at this point probably free that can be duplicated or ordered. And you make phone calls to friends, inform them, get them excited about the issue, solicit their support, and really be creative. At no awareness, people really don't see big billboards. They may not see messages at that point because it doesn't mean anything to them. It's not important to them. One of the examples that I can give you is that when we were writing a grant to explore domestic violence, we drove into town every day, and while we were writing that grant, I looked up and noticed that there was a large billboard about prevention of domestic violence in Fort Collins. And I said, wow, look at that. Fort Collins has a billboard about domestic violence prevention. And Barb looked at me and said, that sign has been there for 4 years. You've just never noticed it. And that was true, because my awareness level had not extended to that point. So that's just one example of not having awareness.
A couple other things that happen sometimes when we get on board about trying to deal with an issue is that, we send out the mass mailings, the emails to people, and when people are at no awareness and maybe even the denial stage or vague awareness, those things are deleted. I know there's probably some of you on the line that have done that. You get an email to please become involved in this kind of thing, or you send a memo. Those things are just not looked at by the majority of people because it's not in their realm to do that. It's an easy way to contact people, but that one-on-one contact, especially at these lower stages of going to someone's place or to seeing them face-to-face, is just critical to get people involved in what you are now becoming passionate about.
If one of your dimensions scores at 2, or denial and resistance, the goal is that the issue does exist in this community, here and now. The strategies can be to meet with people who are likely to provide services that are related. For HIV, we look at people who provide services on STDs or STIs, sexually transmitted infections, methamphetamine, teen pregnancy. Anything that might increase HIV risk are the kinds of things that we look at. We offer educational sessions on HIV or related topics, but we may use those, as Barb called them, safer topics. We might talk about teen pregnancy in a town where pregnancy rates are high, or we might talk about methamphetamine rather than talking directly about HIV. But we will weave HIV into the topic, but gently. We might distribute flyers, brochures, educational information, but we make sure that they're things that are eye-catching, things that are brief, concise, that people can look at quickly. Some of the things that communities have used have been little stand-up cards in restaurants, in local restaurants, that just have a little message about their program, because when people are waiting for their food, they will look at that sitting on the table. One thing that we have learned over the years, and this has come from some of our media studies as well, is that if you put together a beautiful design and put it on your poster or your brochure, people will look at that poster and they'll say, oh, wonder who did that design, and the design will be the focus. They may not ever look at the message. However, if you use people from your community, faces that are known, faces that people know, then people will walk over and say, well, what is John and Mary doing on this poster, and what are they talking about? And they will read the message. So those are just some things to file away, especially for these lower stages for your media. We also see people put information in church bulletins. If you can get your clergy on board and just put a little tiny blurb in the church bulletin, newsletters, any local newsletter that will let you put just a few little words in there. Cafes, school trays, and cafeterias work very well, but choosing places where information is very likely to be seen. That's very important because media can be used, but media isn't always a big blitz or a billboard or television. Sometimes it's very low intensity, but at this stage you have to make sure that it's very visible. At Vague Awareness, the goal here is that the community can make some changes, and it's empowering them in a sense. The strategies, and this is important to remember, is that you can always pick up strategies from lower stages. At Vague Awareness, you can pick up strategies from 1 or 2. You cannot pick up stages from 4 or 5 yet. But at Vague Awareness, you might want to have a booth at some kind of special event that occurs in your community. People have gone to things like powwows, rodeos, health fairs. They might have gone to potlucks, dances, and they distribute their information there. One community that I just learned about recently found that it was considered a negative thing to talk about HIV in their community, and they felt that it created a bad feeling, or in a sense bad medicine. And so this group put together little cedar packets. So with every single brochure that they passed out, they also gave them a cedar packet, so that took away, that was a prayer, and that took away any of the bad feelings that might exist with the information that was given. I thought that was really creative. Another thing is to identify the potential local data sources and what kind of existing efforts are there already that you can latch onto. Maybe there's a group that is already dealing with STDs. Maybe it's just a local clinic and they don't deal specifically with STDs, but they deal with health in general. So if you can get them on board, maybe put a video in their office that people can watch while they're waiting, or put some brochures in their office. That might be helpful as well. People pick up small things like pins or keychains, and they'll take those, and if you can put your message on those kinds of things and leave those around for people to pick up, they often will. And if you have your website on that, that will bring people to your site. And then, as with the previous stages, continue to focus on the topics that the community is really more ready to address that relate to HIV infection, underage drinking and the risk involved with that, meth use, sexually transmitted infections, or substance use. At this stage, you can also use your newspaper to do editorials or brief articles. People may not read a lengthy article, but they are always interested in editorials, and you can develop any kind of creative media that's consistent with that readiness stage. At pre-planning, the goal is to develop practical strategies, things that can actually utilize the resources that are there in the community and be something that can be introduced in a practical manner. Perhaps this is a time to establish the work group that's focused just on HIV and AIDS. Locate and share local information or data that's gathered with the key people who might offer you support. And one little caveat here is that sometimes data is very difficult to access. Not all communities gather data, especially related to HIV and AIDS, in a manner that's common or consistent throughout. So sometimes you have to search for that or look for related data, like STDs or pregnancy rates, or even drug and alcohol use rates. At this stage, you also want to increase your media using newspaper articles, posters, anything that you feel like would gather attention in your area. Sometimes if it's groups that, for instance, government employees that have to use lanyards, lanyards come in very handy if you have your information in your website posted on those. It's a good time to start to conduct informal interviews focused on community knowledge about HIV/AIDS or their willingness to be tested. In one of the communities, we went to their local tribal holiday, and we surveyed about 500 to 600 people with only 2 questions. One was, have you ever been tested for HIV? And the other was, would you be willing to be tested for HIV? And we had a lot of people that responded to that. And we gave away little tiny things that they could take with them so that they had plenty of information for later use. Contacting health providers to gather information on available services is really important. What kinds of things already exist? What kinds of things, if you find someone who is HIV positive in your work, then who do you send that person to? So it's good to have that kind of resource information. You also want to start reviewing existing curricula, the DEBIs, or the diffusion of effective evidence-based interventions, or any other efforts which might be appropriate for the audience that you're trying to reach. 5 is preparation, and the goal here is to begin to gather pertinent information to prepare for implementing a strategy. And if your local data sources don't exist, or if you feel that they're unreliable, then this is a good time to review the related data and really use that. Or try to implement some kind of accurate local data collection. Sometimes that's a challenge, but it's certainly not impossible. With HIV data, we have a lot of challenges getting reliable data. And so that's one of the areas that is under major discussion for us. We present information that has been gathered to community, to providers through newsletters, newspapers. You might reach out now to radio. If you are from Alaska, you know how important radio is there. And in a lot of tribal communities, radio has a prominent place. Perhaps you work with a community or tribal college and can use television. A lot of colleges have local stations that can be utilized, or your local educational station that you can get a little spot on for 5 to 10 minutes and provide your information. If your information can include as many statistics as possible, that's good, but especially if it's local statistics. People don't really care that much about national statistics at this stage, but they care a lot about personal stories. They want to know what the emotional and financial cost is to the community. And I've seen a lot of billboards now that are popping up in communities everywhere that talk about how much a DUI costs the individual. And that made a big impression on me, certainly, to know that you have to attend DUI school, that you have to pay a fine, you have to have an attorney, and it can be very costly to be stopped for a DUI. And those kinds of things can be expanded to include other issues. Search for potential funding, because that becomes really necessary at this point. And the most important thing, network, network, network. Get people on board with your cause and help them to be more aware of what's going on and the importance of your cause. 6 is initiation, and at initiation we want to implement some kind of a community readiness action plan. At this point, you want to engage community providers and leaders through multidisciplinary meetings, in-service trainings, cross-trainings, anything that you can do to inform other people about the progress of your efforts. Network with existing resources. Maybe sponsor or co-sponsor larger community events. If you can get a local business person to maybe make t-shirts for you or to provide some kind of incentive for you, that would be awesome. Plan some kind of publicity efforts to increase the visibility of your efforts. It can be fitness activities, it can be a run, it can be a walk, anything that you might want to offer free testing for, a good time to launch media, and to really talk about how to evaluate what you're doing. As you begin any kind of new effort or new program, evaluation is key because that will really help you for sustainability and help you to inform the community of what you're doing.
Oh, sorry.
7 is stabilization, and at this point you want to stabilize your efforts, and this is when you're really establishing programs, making them stable. So you want to regularly offer community events to maintain support and visibility of your efforts related to HIV and testing. And one of the things that we used to do that was very popular in the community was a Halloween party. We held an annual Halloween party to invite people to come to Community House, which was outpatient drug and alcohol treatment facility. And we wanted to increase our visibility in the community, and we wanted the community to feel very comfortable in our environment and to treat it like it was a place not just of negative things or punishment or treatment, but that they could feel a sense of family there. And that became one of our biggest events for people to come in. After that, we started to have people come in to just sit at the table and have coffee and visit with counselors. And with very little pressure, a lot of them returned for treatment as well. Make sure that you can present evaluation results through multiple media sources at this point, through radio, telling people of your successes. Even if those successes are small, share them because people want to know that you're doing well. Review your efforts and activities quarterly, if possible, maybe more than that at the beginning, so that you can see what you're doing. You can see if your visibility is changing. One of the things that a lot of people do is a pre- and post-community readiness, because you can put community readiness in even at these higher stages, not as a total post after a program is done, but throughout the program. Sometimes the field that we're in, it's very difficult to really see what progress we're making. And community readiness allows you to see that progress because you can see the changes in readiness, you can see the changes in visibility, and you can see the people's change in acceptance of your efforts and your program. And then maintain that networking for business and for other support for the effort or the activity that you put in. The 8th stage is confirmation and expansion, and the goal here is to expand and enhance services, modify them, modify your action plan as needed, and to really start to formalize your networking. You can utilize memoranda of collaboration, memoranda of understanding, memoranda of agreement, or any other kind of collaborative agreement that your agency might use. This is also a really good time to publish and maintain a localized resource directory related to, for our purposes, health, HIV, testing, STD clinics, anything that might be remotely related to HIV. We also like to increase and further develop our media exposure at that point, to expand our outreach and to target additional social networks. We might want to reach out further to perhaps the higher risk heterosexual population for HIV. We might want to try to pull in transgenders at this point, but to try and be as inclusive as possible. And then using your evaluation data to improve efforts and disseminate results to community members, social networks, other professionals, so that you can keep them involved and interested and invested in what you're doing. The last stage, high level of community ownership, is the point where you gain momentum, you disseminate your progress, and you keep your community involved in and informed about your efforts. Sometimes community members will demand to know what you're doing with your money. That's a really good thing because they're interested. Diversify your funding resources at that point. Identify new funding resources. Maintain and expand the local business and community support. Maybe even expand to another topic. Perhaps you found that you're doing really good with substance use and you've got treatment programs in place, you've got prevention programs in place, and at this point you're noticing the high levels of violence. So you want to apply community readiness to violence and begin a domestic violence prevention arm of your treatment facility. And then always continue to track your evaluation data trends. This helps you in grant writing, and it helps you to further expand your program to meet the needs of your consumers. Reliability and validity are very good. We have high face validity, which can be demonstrated just by looking at the scoring sheets, the anchored rating scale, and the questions. Our content validity is very high. Our inter-rater reliability prior to sitting down together to discuss the scoring runs from 9 to 9.2. And then we have so much anecdotal evidence now of things that have changed in communities as a result directly of using the community readiness model. It's very easy for us to go back and do follow-up with communities and identify what our intervention changed in that community, because part of our follow-up is that we go through the action plan, goal by goal, with key people, random people that attended the workshop. So we know what kinds of things actually sprang from and came from the intervention that we provided. And that's something that will be very, very good for your organization to utilize to prove your impact. How can the community readiness model be used? It's been used in a variety of ways. It's been used for research on several different projects. The Office of Juvenile Justice and Delinquency Prevention has used it for engaging tribal communities in participatory community research. It's been used for the National Institute on Drug Abuse for inhalant abuse prevention and to look at methamphetamine use across 2 states. So there's been a lot of pre- and post studies, a lot of treatment and control studies done using community readiness. It's been used for organizational analysis. There was a group in the South that wanted to look at their level of cultural competency for dealing with their multicultural audience. And what they decided to do was use community readiness on the level of administration, the board, the direct service staff, and clients. So they gathered information on 4 levels of readiness to see how culturally competent they really were. There were different levels of readiness that emerged from those 4 groups, and that helped them a whole lot to determine what their next steps would be and how they would remedy that and make their organization more culturally competent, more inviting, and more responsive to what the community needed. It's been used for community-based prevention by many, many, many groups who wanted to look at their readiness stage and build some kind of good prevention or HIV testing so that they could meet the consumer's needs. It's been used extensively for program evaluation because it's easy, it's inexpensive, and it's fairly quick to conduct a community readiness assessment. So pre- and post studies are used a lot for program evaluation. The data that comes from that is both qualitative and quantitative, and the two build on one another so that not only do you have a score to provide to the person that you are responsible to, whether it's your funder or your community or your administrative staff or your tribal council, but you also have qualitative information that informs the quantitative and helps you to build something that is responsive. Applications of the model have been pretty extensive. It's been used for drug use, And as Barb mentioned, we don't really recommend it for substance abuse in general. People feel very differently about marijuana use compared to methamphetamine use. So you have to be fairly specific on what kind of drug seems to be the primary concern in your community. We've used it for alcohol use. We've used it for underage drinking related to alcohol use, and that was done in the state of Ohio by First Lady Hope Taft in her Building Bridges project. And that became a program that has been ongoing even through the next administration. It's been used for intimate partner violence, both on a program level, capacity building level, and also on a research level. CDC has funded 2 studies to our center to look at partner violence from both the male perspective and from the female perspective. It's been used for child maltreatment. In fact, the World Health Organization at this point has funded 5 countries to adapt the community readiness model to be used on a national level to change national policy for the prevention of child maltreatment. It's been used for the prevention of head injury in ski resorts and then also in swimming resorts where people would dive in, and to increase the readiness of people to adhere to the rules and to be more cautious. It's been used for environmental trauma, and this particular issue was one of the first times that we actually used the community readiness model for something other than research. This was done about 15 years ago, and it was a tribal community in the South, and they had had extensive atomic testing done in the 1950s. This residue has now leached into the water systems and has had a big impact on increases in cancer rates. So this group was the group that actually said you need to add no awareness, because our community was so immobilized we couldn't even look at denial. We couldn't do anything. It was just a way of life to be burying people who were 40 and 50 years old. So they did a wonderful job of adapting it and really showing us, teaching us, that it could be used in a venue other than just strictly research. It's been used for disaster preparedness, and in fact we have several graduate students that have come up now and are using it for disaster preparedness in their dissertations. It's been used for transportation issues. Fort Collins looked at it to reduce vehicle miles traveled and try to get people to carpool when gas rates went really high. It's been used for cultural competency, for communities as well as organizations to increase their level of cultural competency. And it's been used for HIV and AIDS, for both research and for capacity building assistance. It's been used for suicide prevention, and we have permission from one of the villages in Alaska, Galena, to talk about their experience with suicide prevention. Galena called us in to help them with suicide prevention because they're a small village, 800 people, about half native and half non-native, and they had had 18 youth suicides in a period of 6 months. And the community was pretty much devastated. Everyone had been touched by the grief and the loss. And so they asked us if we would come in and conduct a workshop on site and help people to build an action plan. Their initial plans included having about 15 to 20 people from Galena there, but they did decide that they would invite other communities just in case others wanted to come in. And it was the first time that six villages had come together to work on an issue. And when we walked in the door, there were over 100 people there, youth, elders, all ages of people, who wanted to make a difference in the loss and the grief in their community. It was one of the most moving 3-day experiences that Barb and I ever experienced, because everybody there had something to say. Everybody had had some sort of loss. But they changed that into an action plan. And each of the villages developed a separate action plan to deal with suicide intent in their village. And then they put together the whole group and developed an action plan to help them to stay in touch and to work together to support one another. In that time, they've had, I think, one suicide, and that's been 6 years ago. But the group has really worked hard, and they tell their story and they help other villages and other communities to share the kind of strategies that they used. Some of these things don't have to cost a lot. One of the impressive strategies that came out of one of the villages in Alaska was that there was a lot of underage drinking going on in one of the villages, one of the smaller villages, and people seemed to be okay with it. It was just the way that things were. So youth were openly drinking in the village, and they wanted to, there was one mother that really wanted to put a stop to that. And so she asked the community to help her to do that. One of the strategies they came up with was to have the youth go to the cemetery, which had been frequently vandalized, and they had them go in every Saturday, and then a family of the people who were buried there would come into the cemetery with the youth while the youth cleaned up that area of the cemetery. That family would tell them about the people that were buried there, what they meant to the community, what kind of jobs they did, and really acquaint those youth with who the people were and what their roots were tied to the people that were buried there. There has not been vandalism in that cemetery now in 6 years, and the youth frequently go in and clean up the cemetery. So that intervention cost absolutely nothing to do, and it brought the youth together with families that they may not have known as well, and it familiarized them with their story, and it gave the youth something creative and productive to do that made them feel good. So that alone was a wonderful, wonderful strategy. It's been used by NASA to look at environmental and weather conditions, and that was done in Chicago high-rises to help people in those high-rises to take care of the elderly during heat waves and to get them prepared to do things and watch out for the elderly and keep them healthy. It's been used for animal control issues such as dog bites, rabies prevention in reservation areas, and then so many other issues have been addressed using community readiness. Some of the products that you receive from doing a community readiness assessment is a practical and quantitative community diagnostic, valuable qualitative information that shapes and informs the strategy development. You get an increased capacity for building additional prevention efforts. You get a very practical structure for creating positive community change and a lot of increased networking capabilities. Some of the successes that we've had over the years, if you'll let us brag for just a moment, is that it's been used in over 2,500 communities throughout the United States over the past 18 years, and probably another 300 to 500 communities internationally. Some of those countries include Siberia, Colombia, Guam, Palau, Australia, Wales, lots and lots of communities. Taiwan. The Community Readiness Manual is now available in Chinese and Spanish as well as English, and it's currently being translated by another group that's using it into German. It's been used for research, evaluation, grassroots efforts. There are over 40 published articles on community readiness that have been done by CSU staff, and we frequently do Googles on community readiness, and there have been about 100 other articles published by people who have used it in other countries. An especially good one is one that was published by a group that used it for alcohol use in Liberia. The World Health Organization has funded 5 countries to use it for the development of national policies for the prevention of child maltreatment. I mentioned that a little bit earlier. And then we also received an award from the First Nations Behavioral Health Association recognizing community readiness as one of the 10 best practices in Native country. It's also been used, and this isn't on the slide, but it's been used by First Lady Laura Bush in her Helping America's Youth campaign. And we went in and provided training for all of the groups that were implementing her project in their communities. As I mentioned before, it's also been used by Hope Tapp, First Lady of Ohio, for her Building Bridges project that was implemented throughout the state of Ohio. We finished just a few minutes early, but that gives you all a little bit more time for questions. So AJ, I think we're ready to open this up for questions.
Great. Thank you very much, Barbara and Pamela. I appreciate that and really appreciate the extent of application that this has in many countries and many cultures. At this time, participants, if you look on your screen, there's a small hand button up in the top right, should be on your screen, that if you press that, I will be able to see that your hand is up, and I will be able to then invite you to ask your question. So at this time, if for those that do have questions, you are welcome to press the hand button, and we'll be able to go that way. That way we'll be able to get your question in. Well, while we're waiting for people to either figure out the technology or if they don't have questions, if we can go to the last slide, please, for the evaluation.
Yes, and AJ, while we're doing that, I do want the people that are online to know that through CDC, we offer the assessment and workshop free of charge to any group, tribal or non-tribal, anywhere in the country. And so if anybody is interested, I think that's kind of our, oops, I'm sorry, going the wrong way. Let me give you that slide. That's our contact. You can contact myself or Pam or Martha, any of us on that slide. But that's our website. And you can get information from either one of those websites about what we do. And contact us. We are, again, at no cost to the community to do that. And, you know, we can do it for HIV and AIDS. And one thing that we've learned from our communities that have asked us to do it on that issue is then they've been able to use it for other issues because they've seen the presentation and we've become a resource for them. And using it whether for alcohol or methamphetamine, then they've got a better grasp of the model since we've been in their community. And I'm sorry, AJ, just before we get to your last slide, I'll let Pam.
One of the thoughts that we always like to leave people with is the great law of the Six Nations Iroquois Confederacy, which is in our every deliberation. We must consider the impact of our decisions on the next 7 generations, and we believe that to be absolute truth. We want to make our communities very healthy for our children, our grandchildren, our great-grandchildren. And then AJ, I'll let you introduce the NACE evaluation slide.
Thank you very much, Pam. You'll see on the slide the link for the evaluation for the webinar. Before you go there, however, I just want to make sure that everyone does have an opportunity for the questions, and I see there's one here. Let me go ahead. Okay, Ray Lewis, you should be able to speak with your question, please. Ray, your microphone is open. If you are on mute, obviously you want to take that off. There, we're going to go ahead and leave Ray's microphone open so that he can work with that. Okay, let me go ahead. There's another question from Pilar. Go ahead, Pilar. Your question, please.
I am just wondering if it's possible to get a PDF version of the slides.
Yes, actually, we are doing two things at NACE, the Native American Center of Excellence. We are both recording this webinar and uploading that to the website, and that we will also have copies of the slide presentation for individuals to download. It'll be in PDF file. Other questions?
AJ, this is Pam, and I have a question for any of the audience members. I'm wondering if anyone has used community readiness at this point for perhaps another issue.
Pam, I'm seeing some additional questions come up, so let's go ahead to those. Patrice? Line is open. Patrice Pichon? We'll go ahead and go to Kelly Cogswell. Your line is open. All right, we'll continue moving on to Jeff Kim.
Yeah, I was wondering if there was a manual that addresses strategies for intervening at the various stages of readiness.
Yeah, yes, there is. If you go to our website, the manual that we have walks you from the beginning of the process to the end and has all the strategies that we talked about. Plus, I think there's some more within the manual. We just presented a few, but within the manual actually has those strategies.
Excellent. Thank you.
You bet.
Thank you, Jeff. Okay, we're going to go back and see if Kelly Cogswell is able to join us. Let me see if there are any other hands raised here. There is one question that was typed in, and this is for both of you, Pam and Barb. And the question was: what's the time amount of time required for a tribal community to modify the community readiness model before implementing into their community on a topic? As an example, if they're addressing the prevention framework, the strategic prevention framework from SAMHSA, and they're trying to address the sustainability issue, and trying to bring community together to address issues related to resources, funding limitations, all of these things that are considerations when you're looking at a sustainability plan. How long does it take for the preparation to work with this model before it's actually ready to administer to the community?
You know, the questions are set, and so, like I said, there's between 20 and 35 questions, and we have a generic template that they can download on our site that it just says this issue, and then you would just put in what that issue is. You know, if you're going to use the term sustainability or whatever term you're going to use. So it would really be meeting with some kind of key people, again going back to defining the issue of what is the issue we want in the question. And so once that meeting has taken place, you know, we've got the template that we can send you. You just drop that in and you're ready to go with the questions.
Excellent.
You know, I would say a couple hours to, you know, at the most half a day.
Okay, I'm not showing that there are other questions here. So I want to thank both of you very, very much. I want to thank you for your patience through our technical difficulties at our first run. And thank you for the information. Thank you for a valuable model that is used in Indian country and many other communities as well. I know that the Native American Center for Excellence will be continuing to explore its application and promotion of this model. So thank you very much. And we will make sure that any requests to us for either of you will be forwarded to you. In the meantime, again, thank you very much for your presentation, and this will end our webinar. Thank you all for
Great.
joining us.
Thank you,
Thank
AJ.
you.